This is Dr. Pat McGinley presenting the lecture that discusses a fairly common and potentially dangerous or life-threatening complication of pregnancy, gestational trophoblastic disease. This condition is known by several names: gestational trophoblastic disease, high datiform mole, molar pregnancy, or simply mole. It is considered a pregnancy, therefore it counts toward the gravida in the pregnancy history. It's a fairly common disorder affecting about 1 in 1,000 pregnancies. It also tends to be more common in the younger or the older reproductive life. So that would be your teens or your older gravidas. Although it has several names, they all refer to the same condition, an abnormality of the peripheral cells responsible for attaching the fertilized egg to the endometrium. It is thought that there is abnormal fertilization by the sperm. The sperm provides duplicate copies of itself and little to no copies of the genetic material of the egg in cellular replication. Typically, there is no fetal development, only placental tissue is present. However, if a fetus is present, it is never normal. The pathology associated with gestational trophoblastic disease ranges from benign to invasive moles and choriocarcinoma. The next 3 slides provide a visual description of what this abnormal tissue looks like. It has no resemblance to a normal early pregnancy. If you look closely at this slide, you can see material that looks like small grapes. The usual signs and symptoms of a molar pregnancy start with bleeding, which, as you know, is a common presenting complaint in early pregnancy. Remember, on the first visit, we do not have the quantitative HCG levels, only a positive urine pregnancy test. Therefore, when this woman presents to the clinic or office, she's bleeding, feeling pregnant, and she may or may not have had a positive pregnancy test at home. So the nurse and the provider follow the usual protocol for investigating early pregnancy: bleeding. Molar pregnancy is in the back of our minds, but the more common things like miscarriage/threatened abortion is on the forefront. Findings that make gestational trophoblastic disease a higher consideration are greater than normal blood pressure for this woman's norm, complaints of excessive nausea and vomiting. Both of these are attributed to the higher than expected quantitative HCG levels associated with gestational trophoblastic disease. But remember, at this point, we do not know what this level is. A pelvic exam is completed by the physician or nurse practitioner, and it will reveal a uterine size that is greater than what is expected at the presenting gestational age. In addition, there is no fetal heartbeat heard with a Doppler, which leads the provider to perform an ultrasound. The thought behind doing an ultrasound is to determine the cause of the bleeding, the actual gestational age. Could this woman's dates be off? We can also see if this is a multiple gestation pregnancy that would account for the size greater than date's uterine size, or finding of gestational trophoblastic disease. The management of gestational trophoblastic disease depends on the extent of the pathology, so let's review. Gestational trophoblasts are cells that invade the uterus, but unlike most cancers, sometimes it knows when to stop. The hydatidiform mole is typically benign and has a very good prognosis. However, an invasive mole may develop into choriocarcinoma or chorioadenoma. The metastatic potential is reduced if it is found early and followed closely. Remember, with gestational trophoblastic diseases, if it's complete, there are no fetal parts. If it's partial, there may be fetal tissue and/or membranes present. The clinical management starts with the diagnostics, doing the transvaginal and/or abdominal ultrasound. We also send off beta-HCG quantitative levels. The treatment include managing some of her symptoms. We can give antiemetics for severe nausea and vomiting. If she does have gestational trophoblastic disease, she needs surgical intervention in the form of a D&C. They do a suction evacuation of the uterine contents followed by sharp curettage of the uterine muscle. So the nurse needs to prepare the patient for surgery. The patient is placed NPO, the procedure is explained to the patient, and you need to get the consents signed. You will also be sending off the admit orders to the surgical suite. You need to collect blood for a CBC, clotting factors, and either type and screen or type and cross-match in case she needs a transfusion. Follow-up for this condition is critical. We follow quantitative HCG levels every 1 to 2 weeks until the result is down to 0, and then follow once a month. Chemotherapy is indicated if the HCG does not fall as expected or it begins to rise again after falling. If chemotherapy is instituted, it usually responds well. Other nursing considerations include patient education and emotional support. This patient is advised not to become pregnant for at least 1 year. The rationale behind this is when a pregnancy occurs, the HCG rises. We cannot tell if this HCG level is rising strictly due to the pregnancy or if the gestational trophoblastic disease is taking a turn for the worst and is developing into metastatic disease somewhere else. So we need to provide a reliable contraceptive method, and the most reliable is the oral contraceptive. The nurse must explain the follow-up to this patient. She must come in for follow-up quantitative HCGs, and she must be taught to call or return to the office if she feels signs and symptoms of pregnancy. Gestational trophoblastic disease is a serious complication of pregnancy. This lecture provided you with the definitions, clinical manifestations of this disorder, as well as the medical and nursing management. Thank you for listening.